Hey, this is Dr. Renaud again, and today we're going to talk about how to manage Alzheimer's disease. The objectives that I want you to be able to do after this lecture are to define dementia, distinguish among the different forms of dementia, describe the available cognitive assessment tools, describe the pathophysiological process of Alzheimer's disease, identify complications of Alzheimer's disease and dementia, list diagnostic criteria for Alzheimer's disease, and discuss non-pharmacological and pharmacological therapies for Alzheimer's disease. So I want to start off by describing what would be considered a normal process of aging and how cognition changes when people age. And I'm going to do that by also comparing it against what might happen in patients with Alzheimer's disease. It is normal for some type of cognitive function to decline with aging. It's always going to be a little bit of a change. It's not going to remain the way it is as maybe a younger person's cognitive abilities. However, the differences should not be as substantial as they are in Alzheimer's disease, and they're usually not nearly as serious. The National Institute on Aging provided this chart, and it's a pretty good summary of what kind of happens to distinguish between these different types of processes in terms of diseases or aging. As you can see, it's more of an alarm sign if something is happening frequently instead of once in a while. You'll notice that with normal aging, maybe decision-making skills might be difficult every once in a while. Maybe there's an occasional missed payment. You'll notice the trend that it's occasional, but you'll see with Alzheimer's disease, it is a pattern. And also, it's a lot more severe, whereas maybe in normal aging, someone might forget what the date is and then remember it a little bit later. With Alzheimer's disease, the person could actually lose track of the date, time, or year. They may not know what year they're in at all. And there may be a little bit of confusion for anyone who's aging in terms of what word to use, sometimes forgetting terms, but that's nothing like in Alzheimer's disease when it's difficult to have an entire conversation. So you'll notice the magnitude of severity is different with an actual dementia versus a little bit of cognitive decline that is just the normal process of aging. So the first thing I want to do is describe what mild cognitive impairment is and kind of explain how it differs a little bit from dementia. In terms of comparing the two, it can be easy to confuse them, so I want you to focus on big things that make them separated from each other, things that can help you keep an eye out on a test, things that would look different if you were to see it on an exam. Daily functioning is a big one. Mild cognitive impairment does not affect daily functioning. That means patients with mild cognitive impairment may have some difficulty with memory, but they can still relatively well take care of themselves. Maybe they can still go to the store, things like that. But patients with dementia are unable to function independently. So you'll see that their actual ability to be able to do everyday tasks is impaired. With mild cognitive impairment, it's often reversible because there can be other things causing it that maybe those things need to be treated and then the cognitive issues can be resolved. However, dementia is a progressive and terminal condition. It's a process of neurodegeneration and it's never going to be reversed. So that's why we equate dementia with an irreversible process. In terms of mild cognitive impairment, there may be some memory issues, but dementia, it is severe. And also I want you to focus on causes, and I've touched on this a little bit. Again, mild cognitive impairment, it may be something like a structural thing or a medical thing, maybe a medication can cause it. Sometimes even Alzheimer's patients can have mild cognitive impairment. So there is a chance that sometimes it is dementia induced, but it is also possible that it's not. And a lot of times it's not. So if it's medication induced, things like that, you can treat the problem and then the symptoms should go away. However, with dementia, as we said, it is progressive because there is a structural problem with the brain and the neurons in the brain are actually breaking down, and that kind of damage is not going to be able to be repaired. So it will continue to deteriorate and the patient will continue to decline in terms of cognitive function. So when we're considering dementia, we have to remember that there are multiple types of dementia, and I'm going to discuss this in patient care, so I don't want to really harp on it right now. I do want you to make note of the fact that dementia by itself is technically not the diagnosis for a patient. A patient would be diagnosed with the conditions I have listed on the slide because dementia is just an umbrella term for specific diseases or specific types of dementia. So, dementia is a general term that covers a decline in memory, reasoning skills, or thinking skills. But when we're looking at a patient, we can't just say, oh, that person has dementia. We have to know what is that memory symptom attributed to. And 60 to 80% of the time, it will be Alzheimer's disease. That is a type of dementia. There could be vascular dementia and these other types I have listed here. Again, I'll discuss those in patient care. But I really want to make it clear to you that dementia by itself is not really a disease. It's just describing the symptoms that we see, and the diagnosis would be what's on the slide. When we're considering Alzheimer's disease, I think it helps to look at what's actually going on a lot of times in the brain. So I do have this figure included. And look at the picture. You'll notice it's kind of subdivided into two halves. The half on the left shows what a normal brain structure would look like, and the structure on the right is a brain with Alzheimer's disease. Remember that the ultimate process of Alzheimer's disease is nerve cell death that leads to brain shrinkage. The brain actually starts to shrink. And that happens because look at how in the Alzheimer's brain there are those lesions that you see. They look like little red blotches. Those are called amyloid plaques. And those clearly should not be there. They start taking up space in the brain. And then on top of that, you'll see that the neurons themselves, the ones that are in the normal brain, don't have a lot of lines and tangles in them. But you'll see in an Alzheimer's brain, there are a lot of tangles, and these neurofibrillary tangles, as they're called, contain high concentrations of something called tau protein. And tau protein has been linked to cell death. So both amyloid plaques and neurofibrillary tangles can lead to extreme brain damage, which causes that neurodegenerative process inside of Alzheimer's patients. When we consider patients with Alzheimer's, we usually categorize whether they are early onset or late onset, and that depends on the age that they develop the condition. If they're 65 and older, we tend to call it late onset, but if they're under the age of 65, we call it early onset. And the memory type that usually gets affected with Alzheimer's patients is short-term memory. And this makes sense because Alzheimer's disease actually will cause shrinkage of the hippocampus. And remember that the hippocampus is the learning center portion of the brain. So if the part of your brain that's responsible for laying down new memories, things like that, starts to shrink, it makes sense then that your short-term memory would be the first thing to go. So short-term memory is definitely declining when patients do get Alzheimer's. In terms of survival, unfortunately, it's pretty variable in terms of how long a patient lives after diagnosis. It could be anywhere from 3 to 20 years. There's a lot that goes into play there. There's no way to really predict it. The ultimate cause, though, will be death. It is a terminal, progressive, fatal condition. There's no cure. And what tends to happen is the patient will start to lose the ability to perform basic tasks like going to the bathroom, eating, drinking, and then that eventually leads to weakness and frailty. And when the patient becomes weak and frail enough, that patient becomes very immunocompromised, and then they're more likely to get infections or die from conditions because their body simply can't fight it off. So, I want to discuss some trends of Alzheimer's and also risk factors. Before I get too far, I do want to remind you guys that the information that we cover in patient care, you'll be responsible for that information, and it's going to be important for this class as well. So, make sure that you're reviewing the information from patient care, not just the packets from gerontology for Alzheimer's disease. When we do look at Alzheimer's patients, we'll notice that there is a genetic component that increases the risk of developing Alzheimer's. I'll discuss that way more in depth in patient care. Just know for now that there is a genetic component, and family history does play a role in that. Also, age is a risk factor. As people age, they're more likely to get Alzheimer's. 65 years of age is usually the cutoff. They find that as someone gets over the age of 65, the risk of developing Alzheimer's actually doubles every 5 years. In terms of trends, women are more likely to get Alzheimer's than men. That could be because men who live past the age of 65 tend to have better cardiovascular profiles, and that may allow them to have fewer cases of Alzheimer's, but there's no way to know that for sure if that's why. Also, there are more cases of Alzheimer's in Hispanic and African American ethnicities than other ethnicities, so there seems to be a trend there. In terms of statistics, it is the fifth leading cause of death in people ages 65 years and older. When diagnosing Alzheimer's, remember that it is a clinical diagnosis, and that means that in order to make a diagnosis, other conditions have to be ruled out. So I have listed other things that might cause some cognitive symptoms that might be confused potentially with Alzheimer's. And again, these things need to be ruled out before one could claim that someone has Alzheimer's. We'll discuss why these factors affect cognition in patient care. Just note for now that they do lead to cognitive effects, especially delirium. And remember that things like B12 deficiency, that can cause pernicious anemia, and that can impair cognition. And then also keep in mind that delirium can be induced by a number of things, including infections. And usually those infections would be things that can cause neurological symptoms like maybe syphilis or HIV, because remember that syphilis and HIV can both cause CNS involvement or other brain infections. So in order to diagnose Alzheimer's, we need to rule all of that out first. It can sometimes be difficult to distinguish between delirium and dementia, so I do have a chart here for you. And there are some things that make them seem very similar, but if you focus on the few telltale signs that kind of distinguish them, I think that'd be the easiest way for you to keep it straight. When you're considering things like delirium and dementia, focus on when the symptom onset occurs, because in delirium, it's usually pretty sudden onset because it's usually caused by something else. And with dementia, it's a gradual onset and it's progressive because remember, as neurodegeneration continues, there's a stable decline, if you will, of mental function. So if all of a sudden, out of nowhere, there seems to be some type of cognitive impairment, it's probably not dementia because it's less likely that that kind of degree of impairment and damage would happen so quickly. So it would make more sense that there's another cause. Also, I want you to focus on whether or not it's caused by something structural or something else. And this kind of links back to what we talked about with mild cognitive impairment and dementia. Remember that with delirium, it could be caused by things that cause trauma, like medication, surgery, illness, things like that, traumatic events, things like that. With dementia, morphological causes will be the ultimate symptom cause. So if a patient has some type of a structural problem, that's what will be causing the symptoms, not necessarily because a medication causes cognitive issues. Reversibility is a huge one because, again, delirium is usually reversible. So if you can remove the stressor or traumatic thing that's causing the delirium, usually it can go away. But with dementia, again, it will not go away. It's terminal. Lots of medications can have cognitive effects. I do want to try to focus on medications that might be more likely to be seen in geriatric patients. So remember things that affect patients and cause sedation, drowsiness, anticholinergic effects. Those are things that we're going to be looking out for. So I've listed a few examples, one of them being anticholinergics, because as we know, anticholinergics can cause confusion and CNS symptoms. Remember that antipsychotics in elderly patients should be avoided, especially in elderly patients with dementia. This may lead to stroke or other cerebrovascular events that can be very dangerous. Also, muscle relaxants can cause CNS effects, and TCAs can cause cognitive impairment and confusion because remember, they also have anticholinergic effects. So this list is not everything that can cause cognition issues, but it is a pretty good list of common medications that geriatric patients might use. For your first lecture embedded question, I want you to, again, make sure you're using AMA citations. Write which of Mrs. Penny's medications could cause symptoms of cognitive impairment and explain your answer. So be sure to actually elaborate on it, not just give me a list of medications. For your second lecture embedded question, I want you to describe what behaviors or medical conditions may be contributing to Mrs. Penny's cognitive symptoms. So there are clearly going to be a lot of complications of Alzheimer's disease. The primary one, of course, is mortality because remember, it is fatal. There is no cure. Also, there is this progressive decline in cognition, and that is more than just a problem with struggling to remember things or having trouble thinking clearly. It's also struggling to maintain independence because as a person continues to decline, that person is going to eventually lose the ability even to do things like go to the bathroom, walk, speak, swallow, eat. And that can actually lead to a few things. It can lead to depression or other psychiatric things, but it can also lead to caregiver burnout, to where the people who are taking care of these patients are less likely to be able to handle the stress of being a caregiver because of all of the pressure that they're under. So there are a lot of issues that arise from this. When diagnosing Alzheimer's, we do use the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, known as the DSM-5, and I have broken it into a chart, and I've done two screenshots for you so that you can read it a little bit easier. So this slide and the next slide will contain screenshots of the DSM-5. You'll notice that when we're diagnosing Alzheimer's, the first criterion, of course, is that there has to be a significant cognitive decline in an area like learning, memory, attention, motor function, something like that. That's known as a cognitive domain. Also, the cognitive decline has to interfere with the patient's daily life and cause difficulty performing necessary daily tasks like paying bills, things like that. And of course, things like dementias, other ones, of course, disorders and delirium must be ruled out. Another thing to note is that the cognitive impairment that's observed has to occur in more than one cognitive domain. So that means that if a patient has cognitive decline in learning and memory, it would have to occur somewhere else, like maybe also perceptual motor domains. And refer again to the domains on the previous slide to see what the different ones are. There needs to be a combination of at least two of them. When Alzheimer's is diagnosed, it can either be diagnosed because of genetic information Or it can be diagnosed if the following three things are present. If there are factors like memory decline or cognitive decline that progresses, and no other conditions are present that affect cognition, then maybe that can also be considered a diagnosis. Of course, it would be preferred to actually have more of a definitive thing like a genetic mutation to be more accurate in terms of diagnosis. Now I want to discuss some symptoms of Alzheimer's and how we can screen for it. And you'll notice that symptoms, they're pretty self-explanatory. There's obviously going to be memory loss and confusion, but there's also something you may have never heard of that's called sundowning. And I'll get into this a little bit later, but it's basically a behavioral change that happens around sunset in patients with Alzheimer's disease. In terms of screening, there are some tests, and we're going to discuss some of them, some more in depth than others. We have the mini-cog, the MMSE, the MoCA, and the SLUMS test. And I want to make it very clear that all of these are screening tools only. We do not diagnose Alzheimer's with these tools. We simply use them to try to point out what might indicate maybe a cognitive issue that needs to have further screening done, further testing done. We cannot diagnose Alzheimer's with these tests. Also, some of them take longer than others. The MoCA and SLUMS tests do take a little bit longer, so we're not going to be able to go and show all of the steps involved in doing those tests, but I do have some pictures that can show what's involved with a mini-cog and MMSE because they're a little bit faster tests. Again, remember that the mini-cog is not used to diagnose Alzheimer's or dementia. It's simply a screening tool. Further testing is required to make a dementia diagnosis. It can see if there might be cognitive impairment, but that's about it. It can't actually diagnose anything. So with the mini-cog, it is a 5-point scale, and it's broken up into two different aspects of the test. There's an item recall part and a clock drawing part. And the item recall part is where the patient is given a list of 3 items to remember, and these are actually standardized items depending on the version of the test that's used. So the patient has to be able to recall those 3 items when the administrator of the test asks for the items to be repeated. And the clock drawing part, the patient is going to have a blank circle in front of him, and they're going to have to label the clock in the correct order in terms of numbers, and then they're going to have to put the hands of the clock at the time that the person giving the test tells the patient to point the hands at. So if they wanted them to point it at 3 o'clock, for instance, the patient has to be able to draw the hands at the correct placement. So for scoring, I don't need you to know that it's 3 points for item recall and 2 points for clock drawing. I just thought that that would be kind of interesting for you guys to see. So each word that they can remember would give them a point, and with the clock, if they can put the numbers in order, they get a point, and if they can put the correct time, that would also be a point. And so that would lead up to the 5-point maximum. It is used again to show whether there might be an indication of potential need for further testing of cognitive impairment. Again, it's not diagnosing anything. If a score is less than 3, that is where they might start suggesting further testing being done. But remember that even if someone gets a score of 3 to 5, there might still be some impairment, so it's not completely accurate. The next 2 slides are going to show the actual mini-cog steps, and I've broken it up into 2 screenshots so that you can see it a little bit better. These are in your packets. So you'll see, again, they've got the versions of the items that they have to remember. They've got the clock drawing, and then they have to be able to repeat the words that they're supposed to remember. This is the other picture that's in your packet. and this is just what the patient has. They get a blank.
Hi, Colleen. It's nice to see you.
Thank you. It's good to be here.
It's been about 6 months, I think, since your last clinic visit.
Yes.
I understand from the nurse that you're here because of some dizziness that you've had recently.
Yes, I am.
Yeah, sounds pretty bothersome.
It is.
Well, before we look into that a little bit more, we're doing something new in the clinic, which is that just like the nurse was checking your vital signs, your pulse, your blood pressure, we're now also checking the health of the brain on a routine basis.
Okay.
And so I'm going to ask you some questions next that require a little bit of concentration. Sound okay?
Okay.
Okay. The first thing is I want you to listen carefully because I'm going to give you 3 words that I want you to repeat back to me and try to remember for later.
Okay.
You ready?
Mm-hmm.
Okay. The words are banana, sunrise, chair. Can you say those back to me?
Banana, sunrise. I don't remember the last word.
Okay. The 3 words are banana, sunrise, and chair. Can you see those back?
Banana, sunrise, and chair.
Great. Now, I'm going to give you this piece of paper with a circle on it, and what I want you to do is make a clock for me by putting in all the numbers where they go. Now, Colleen, can you set the time so it says 10 past 11? Okay, I'll take that back from you. Now, what were those 3 words that I had you repeat earlier?
Sunrise, banana, shampoo.
Okay, great, thank you. Colleen, have you had any concerns about your memory recently?
Yes.
What kind of concerns?
That I'm forgetting a lot.
Okay, what kinds of things have you been forgetting?
Things that I'm supposed to do during the day that I normally do.
Mm-hmm.
Or like when I go into a room to get something, I don't remember why I'm in there.
Mm-hmm.
And then I start cleaning and doing other things, and then I remember what I went in for, and sometimes I don't.
Mm-hmm. That's really frustrating.
Very.
Well, maybe once we're done with today's visit, it might be a good idea to have you come back so that we can look into that a little bit more. Would that be okay?
Yes, that would be fine.
Okay, sounds good.
So this chart here basically summarizes kind of what we saw them doing in the video and how the mini cog is actually scored. You'll see that the points add up to that total of 5 points, and scores under 3 could potentially indicate cognitive impairment or dementia. But again, nothing is actually formally diagnosed from the mini-cog. The mini-cog is just a screening tool to determine whether further testing is required. Here I've listed the scoring for the MMSE, and I'm not going to go too much into detail because I know that you guys have had it before. I do want to make note and make sure that you guys understand the fact that these scoring ranges that I'm giving you may look a little bit different from what you may have seen earlier. That's because my scoring ranges are based specifically on staging Alzheimer's disease. The MMSE scoring can vary on factors like age, education, race, and ethnicity, but also they can change if we're screening for different things. If you're screening for cognitive impairment, there may be a different scale as well. So keep that in mind. I need you to know these scores But these scores aren't necessarily contradictory of anything. It's just how we're staging Alzheimer's. That's how we're using the MMSE for this purpose. And you will find the scoring range that we're going to use in the DePiro book in table 71-2. And you'll notice that it will distinguish the Alzheimer's stages into mild, moderate, and severe. And patients who are normal will have a score of at least 27. But when a patient gets into the score range of about 20 to 26, that's where we get to mild Alzheimer's. And those symptoms, the patients are still relatively independent, but they may have some trouble with household activities. They may get lost while driving and may have some trouble remembering things. When a patient develops moderate Alzheimer's, that's when the MMSE is usually between about 10 and 20, and that is characterized by extreme disorientation, like they don't know the year, the date, the season, etc. There may be mood and paranoia symptoms, and patients may also even forget their family members and details about past events. Severe Alzheimer's will usually have an MMSE between about 0 and 9, and that's when the patient is usually almost completely incapable of living independently. They're likely unable to eat, drink, go to the bathroom, or even speak. So I have included a picture of this screenshot in your handout, and this is the first half of what the MMSE actually looks like in terms of the scoring sheet when a person giving a test is keeping track of the patient's score. And so this is the first half of the test, the kinds of questions that the patient would be asked. Here's the other half of the written MMSE test. And again, remember that this picture is also in your handout just for your reference. I don't expect you to have this memorized. This is a screenshot of table 71-2 from your DePiro book. It is the scale that I want you to know for the class because again, this is how Alzheimer's disease is staged in terms of the MMSE score. So be sure that you know these score ranges and do remember again that these values may vary depending on whether you're screening for cognitive impairment or if you're staging for Alzheimer's, and also other things like education like we discussed earlier. So there can be variation, but you should know this particular scoring range for purposes of this class. Now we will discuss the MOCA test, and the MOCA test is too long to actually show a video of or to show all the aspects of it. So I just want to do a brief overview, and I want you to focus on the scoring thresholds. I don't need you to know all of the different areas that are tested and how many points are associated with them. That's just for your information. So in terms of the MOCA test, a patient will also be drawing a clock in this test. Believe it or not, a lot of these tests do involve drawing a clock. This test is on a 30-point scale, sort of like the MMSE, but there is now a threshold of scores anywhere 25 and under indicating impairment. And again, this is also subject to variations. Some test administrators prefer to use a lower score threshold to indicate impairment, but since we are going to be using the website's scoring ranges, I'm going to go ahead and just have you look at those. So make sure you know that anything 25 and under for purposes of this class will be indicating impairment, but you may see different scoring depending on a different test administration. And again, so normal would be 26 to 30, mild would be 18 to 25, moderate would be 10 to 17, and severe would be 0 to 9. And education can affect the scoring, which is why there may be variation. Now we're going to discuss how to score the SLUMS test. And again, this test is too long for me to show you a whole lot of information. I just kind of want you to know how to score it. And the score ranges are very much dependent on whether or not the person completed high school. There are completely different score ranges depending on high school completion. you'll notice that if someone did complete high school, then they should be getting at least a 27 to be considered to have normal cognitive function. And scores between 21 to 26 indicate some type of a mild neurocognitive disorder, and then anything 20 and lower would indicate some type of dementia. When a patient does not complete high school, then they can score as low as 25 and still be considered having a normal cognitive function. And then scores of 20 to 24 are considered mild neurocognitive disorder, and then 1 through 19 would be considered dementia. In the SLUMS test, they'll ask questions about what day, year, state the patient's in. They'll ask patients to remember names of objects after a short period of time. They'll have to do some math calculations, list how many animals they can think of in a minute. They might have to spell some words or numbers backwards. They might have to draw a clock, make some shapes and mark them, and answer questions after being told a story. So it is a bit of an involved and kind of long test. In terms of goals of therapy, it is important to overall, most importantly, slow the progression of the disease. Improving the symptoms of Alzheimer's can slow the progress that will lead to a lack of independence, and it can also lead to an improved quality of life. It's important that caregivers are educated about how to take care of patients with Alzheimer's, because eventually they are going to have to help them do things like eat, drink, go to the bathroom, things like that. Also, the therapy that the patient receives should be geared towards promoting as much independence as possible with as few side effects as possible, because we want to make sure that the patient continues to take the medication and is basically adherent to medication, because if they're not taking their meds, then there's a risk that the treatment will not work as well. And then again, there's going to be that lack of independence that will develop, and that can lead to a whole host of complications, including a lot of depression for the patient. I'll go more in depth in non pharmacological therapies in patient care, but I do want to discuss a few of them. It is important, no matter what, that you always take the opportunity to see if someone is willing to consider smoking cessation. Smoking can actually exacerbate dementia, so that would be a good non pharmacological therapy, pretty easy to implement if the patient's willing. Also, education of both caregivers and patients is important. They should know things about the condition itself, what to expect, the severity of disease progression, maybe how to be a caregiver, and when a nursing home might be necessary. And also, caregivers need to know how to help the patient relax when they start to lose the ability to be independent, and how to help them with hunger, thirst, using the bathroom, etc. In terms of sensory impairments, that has to be managed, because a lot of times when a patient loses the ability to see, hear, those sorts of things, environmental triggers may cause some discomfort or even behavioral symptoms. So we'll discuss that a little bit later, but managing those sensory impairments can be very beneficial. Also, a healthy diet, and then just helping the patient relax. Anything relaxing, things like music therapy, massage therapy, whatever is going to help the patient let go of some of that stress and maybe ignore some of the external stimuli that might be around. For your third lecture embedded question, I want you to answer and explain about what non-pharmacological recommendations you would make for improving Miss Penny's cognitive symptoms. Here are the pharmacological therapies that we are going to be considering for patients with Alzheimer's. You'll see that I have some dementia therapies listed, as well as some therapies for neuropsychiatric symptoms. And we're going to focus primarily on clinical pearls, dosing, and general recommendations for choosing a treatment in here, because in patient care, I will give you more specific information about the actual drug information, but you will be responsible for it, so make sure that you're studying your packet. Note that we've got different classes. We've got acetylcholinesterase inhibitors. We have our NMDA receptor antagonist, memantine, and we also have combination therapy You can do an acetylcholinesterase inhibitor with memantine, or you can do donepezil with memantine, which is a combination product that we will discuss shortly. So on this slide, I primarily want you to focus on, of course, the information that is going to be discussed in patient care, but as well as the formulations present, like ODT, patch, solution, things that can be good for swallowing difficulties. Because remember that many Alzheimer's patients will eventually lose the ability to swallow. They'll have a lot of trouble swallowing, and they will need medication that can be administered without much difficulty. So I want you to know what kinds of unique formulations there are. And I also want you to focus on the fact that some formulations are not available in certain strengths. You will not find an orally disintegrating tablet for donepezil in the 23 milligram strength, for example. So be sure that you're paying attention to what strengths are available for each formulation as well. I want to go over the clinical pearls and patient counseling information for acetylcholinesterase inhibitors because the rest of this information you're going to get in patient care. Focus on the fact that with medications like Aricept, as the dose goes up, the GI effects also go up, so you may see an increase in weight loss. Also remember that all of the acetylcholinesterase inhibitors do have options for people who can't swallow. I've listed them here. And that patch form is also available with ribostigmine. In terms of counseling, it is preferred for patients to take Aricept at bedtime because that helps them maybe sleep through some of the uncomfortable side effects like dizziness, GI issues, etc. But if the patient does have insomnia, they may prefer switching the dose to the morning if necessary. And no matter what, you should always be counseling patients on fall prevention methods. Remember that these medications may cause bradycardia and dizziness, and that would be a problem in terms of fall risks. So we should be counseling patients about how to avoid falls. I've listed all those fall prevention methods there. And then this is also important. The galantamine ER capsules, they cannot be opened and sprinkled. And you are going to see that Namenda can and Namzaric can, but not galantamine. So I want you to pay attention to that. So you should not crush and chew capsules ever, but also tell the patient not to open it and sprinkle it. They need to be taken whole. Of course, we're going to go more into dosing and patient care. I do want you to make note of this titration schedule. It's going to be very important because I don't want you to think that in a certain severity of Alzheimer's that it would be appropriate to jump up to a high dose, for instance, of donepezil without working the patient up to it. There should always be titration, and it should always be from a low dose to the maintenance dose. And you'll see that no matter the severity of the Alzheimer's, donepezil should be started at 5 milligrams nightly, and then it can be increased. After 4 to 6 weeks, the patient can be increased to 10 milligrams. And if it is necessary to go to 23 milligrams, they need to be able to tolerate 3 months of the 10 milligram dose. And you'll see that the Exelon patch is titrated on a monthly basis, and the galantamine is titrated every 4 weeks. Also pay attention to BID dosing versus daily dosing because that can affect adherence.